Welcome to Part 5 of Care of Patients with Malnutrition or Obesity lesson. In this lesson, we will be discussing obesity and surgical management. Obesity, like cancer, is not just one disease, but instead many conditions with varying causes. Obesity refers to an excess amount of body fat when compared with lean body mass. Presently, more than 72 million Americans are obese today. The major complications of obesity affect primarily the cardiovascular and respiratory systems. However, excess weight can also cause degeneration of the musculoskeletal system. Obese people are also more susceptible to infections and infectious diseases than are thinner people and tend to heal more slowly. Most common complications associated with obesity are type 2 diabetes mellitus, hypertension, hyperlipidemia, coronary artery disease, stroke, depression, behavioral health problems, urinary incontinence, decreased wound healing, peripheral arterial disease, metabolic syndrome, obstructive sleep apnea, obesity hypoventilation syndrome, cholelithiasis, gout, chronic back pain, or early osteoarthritis. Non-surgical management of obesity include diet programs, nutrition therapy, exercise programs, drug therapy, behavioral management, and complementary or alternative therapies. Surgical management includes bariatric surgery, which is a reduction of gastric capacity to 15 mL, and they may have increased risk for complications. Operative procedures include gastric bypass, vertical banded gastroplasty, or circumgastric banding. Post-op care will include a length of stay about 24 hours to 5 days. They're going to have pain. They'll start off with a PCA pump and then they'll move to the oral opioid analgesias. You will have bariatric equipment. There will be an NG tube. You never want to reposition the tube. It can disrupt the suture line. The diet will be advanced slowly. They'll get like 1 ounce servings. It'll start out with liquids pureed for the first 6 weeks, and they'll get 6 small feedings per day, and then they're going to avoid fluids with about 30 to 45 minutes before and after meals. So some of the complications or risks that are associated with this type of procedure is they could have wound dehiscence. Abdominal binder is needed at all times. You want to make sure that they have a patent airway, and you want to monitor their skin integrity. They could have depression, and like I said, the 6 small feedings to prevent the dehydration. If they get too much fluid, results in nausea and vomiting. So you want to monitor for signs and symptoms of the dumping syndrome. So you can go in your book on page 1355 and review the chart 63-7 for more details. Okay, so some of the signs and symptoms of dumping syndrome are tachycardia, nausea, diarrhea, abdominal cramping, diaphoresis, and vertigo. It can usually occur 15 to 30 minutes after a meal. And this is due to a large bolus of hypertonic fluid that enters into the intestine, and then fluid is drawn into the bowel, which causes the distension of the bowel. Advise your patients to lie down. This will pass. So remember, the RN is responsible for assessing, monitoring, teaching, and developing the plan of care. You can delegate to the LPN task-oriented procedures such as administering tube feedings or checking residual. And delegate to the nursing assistants tasks that require no assessment skills such as daily calorie count and fluid intake. This concludes Part 5 lesson of care of patients with malnutrition or obesity. If you have any questions related to the lesson, contact the instructor.